not just any type of sharing, and this is my second concept. The second ingredient is a sharing in reciprocity. It's really reciprocal learning, and those of us who have been participating in tutorials know it very well, because each of us will learn from the others. We shall learn from the clinical cases presented by the national leaders. We shall learn in many different ways, and this is very important. Reciprocity. The third ingredient of tutorials is interactivity. And there will be interactive clinical cases, for sure. I will also suggest that each of us, at the time of the coffee breaks, at the time of the breaks, we have interaction one with the other, because interactivity is individual interactivity is extremely important, and is a very serious ingredient of the success of the conference. I see many young people in the hall. This is very good. And I invite really all of them not to be ashamed of posing questions. Please interact in the session, but also, as I said, in the rest. The tutorial started in Europe, in particular in Eastern Europe, but then later, little by little, they expanded to many continents, to Asia, and we are here today. Also, but we had tutorials in many Asian countries, in Africa, in the Americas. I think we didn't have tutorials in Oceania for the moment, but who knows for the future. But at least in 4 continents, we really had many tutorials throughout the age. And I had the privilege of chairing the Global Outreach Program Committee, and I had the privilege to know the Hematology Society of Bangladesh in Kolkata a few years ago, I think in 2018 or 18. And there we planned to have a tutorial in Dhaka. That was a very initial plan. Then the pandemic came, as you know, everything had to be a bit late, but here we are. So thanks very much to the leadership, to the president and all the leadership of the Hematology Society of Bangladesh for hosting us here. And another important ingredient of tutorials is hematological friendship. It's not only sharing knowledge of clinical cases, but also establishing long-standing relationships. Thank you very much indeed.
Thank you, Professor Gianluca Gaetano. He is the father of this EHA tutorial, is the brainchild of this tutorial. So we are really happy of the presence of this Professor Gianluca. And with this note, this tutorial is officially open. Hopefully all of you enjoy and collaborate and fostering the knowledge. Thank you all.
Assalamu alaikum and very good morning to everyone. I'm Dr. Tanveen Rahman, welcoming you all to our scientific session. We begin with our session 1, focusing on one of the toughest challenges in hematology, resistant and relapsed acute myeloid leukemia. We have with us Dr. Priyanka Mehta from the United Kingdom, consultant hematologist at the University Hospitals Bristol and Leicester NHS Trust. She specializes in myeloid malignancies with a focus on AML resistance, chemosensitivity, and genetic assessments in therapy planning. She also serves on the AML Authority and leads the AML initiative. We want to welcome to Bangladesh. And Bangladesh will be followed by insights from Bangladesh, which will be presented by the hematologist and overall counseling specialist at the United Hospital. And then we have third assistant case, which is provided by Professor Priyanka Mehta,
No sound.
This talk. It's a real privilege. I'm going to be starting this whole session of tutorial with a slightly difficult, complex, and at times depressing topic, which is talking about relapse and refractory AML. But hard as it is, we have to tackle this problem very frequently, unfortunately. And so it's spending some time in how, what our approach should be and how we go about managing relapsed AML patients. So I'll start with, these are my brochures. So the objectives of the session today are to understand the laboratory diagnosis of relapsed refractory AML and the utilization of detecting minimal residual disease, or what we now call measurable residual disease, which is MRD. The next objective is to approach the management of a patient with relapsed refractory AML, and both in all kinds of patients, the fit patients, unfit patients, and the patients who already had a stem cell transplant. And lastly, to familiarize ourselves with the development of novel targeted agents and immunotherapies which are being developed, so we are aware of them, and when they are, they've gone through clinical trials and are available to us, we may be able to use them. So the plan for my talk is to start with the very basics for those of you who are training in hematology, the definition of relapsed refractory AML, then discuss laboratory diagnosis, prognosis of relapsed refractory AML, talk about treatment goals, which I think is very important with every patient, is to decide what the patient expects and what we ought to be doing in that regard. And then talk about the salvage options, talking about emerging treatments and immunotherapies. But to me, the most important part of the talk really is about how do we reduce the risk of relapse. And so I'm going to spend a little time there. Then we talk about managing relapse post-transplant. What about patients who have relapsed more than once, and talking about second salvage therapies and outcomes. So relapse unfortunately remains very common and the major cause of treatment failure and death in patients with AML. Even after stem cell transplant, almost 50% of our patients suffer from relapse. And the rate of achieving a second remission and long-term survival actually not very good, and it's dependent on the age, the risk group, what previous treatments they have had, and can be quite low as 5 to 10. And the aim is really to try and reduce relapse by applying some maintenance therapies or MRD monitoring and treatment. So these are the European Union definitions for relapsed AML. These were developed and revised in 2022. And you can see that refractory disease is AML in a patient who is not responded to 2 cycles, 2 treatment regimens. Relapse disease is when patient has achieved a remission but has demonstrated a recurrence of the disease on 2 consecutive manner. And treatment failure now also includes patients who have molecular relapse, in that they could still be in morphological remission, less than 5% just on the microscopes. But if you have a marker like either NPM1 mutation or your patient has co-binding factor AML, and if you show that there is a 1 log increase in the level of disease, again on more than 2 consecutive manners, then that is called molecular relapse. And so setting goals of treatment and approaches in a patient with relapse refractory AML. Needless to say, each patient is going to be different. So we have to individualize our plan for the patient. If you have a 35-year-old who's relapsed as compared to you've got a 70-year-old who is relapsed. What the patient's experience through their first round of AML has been, what is the disease biology, etc. So the things we take into consideration are age, the fitness of the patient. It is usually, the treatment can be quite intensive, and so it's very important to know whether the patient is going to be able to tolerate the treatment you're planning to offer. And comorbidities, what is their vital organ function like? We think about cardiac, renal, liver, but it's equally important to think about lung function, particularly if they've had recurrent chest infections or long smoking history. And again, they might have withstood their first round of treatment for AML quite all right, but it's very important to reassess those organ functions. Again, every patient is different, every patient's level of education, understanding, and their personal inclinations towards how they want to fight the battle. What is the situation with their socio-economic support, what kind of family support they have, etc. It's important to get this patient's understanding of the situation and what their expectations from treatment will be like. Disease biology is paramount, as we will hear throughout the talk, that there are some diseases where the outcomes are going to be just so poor that will vary in what kind of treatment plan you make for the patient. And the likelihood of response to salvage chemotherapy. Quite often we start off with, when a patient has a relapsed refractory AML, we start off with, is this patient eligible for transplant or not? And I will show you a flow chart. And also, it's quite nice to be able to offer a patient the option of a clinical trial, because it usually means that they may have therapy that is still experimental but might be beneficial for them. So this is about the laboratory diagnosis of relapsed refractory AML. Needless to say, you've got a patient relapse, so you've done a bone marrow biopsy, and you looked down the microscope to demonstrate that the AML has indeed relapsed. But at this point, it's also important to repeat the mutational analysis of the patient, because we know that in AML, when the disease relapses, there is a clonal evolution. And these clonal evolution can have therapeutic implications. Your patient might have acquired a mutation that might tell you how better or how not to treat them. Detecting relapse early requires MRD assessment. So at the time of the first presentation of AML, it is worth finding out which is the best marker for your patient. Is there a co-binding factor? Is there an NPM1? Or are you going to depend just on flow cytometry for disease at a lower level? And NGS-based MRD assessment, except for NPM1 and CBF and APLs, is not routine practice. I put here two papers, one from our British Society of Standards and Hematology Guidelines, which we produced, for what tests should be done in AML patients, both at diagnosis and relapse. And then there is the ELN diagnosis and management of AML in patients in 2022, the recommendations from ELN. So these two references are quite useful for those of you for practice as well as if you're preparing for exams. So let's talk about estimating prognosis for adult patients at first relapse. Now this, for the first time, was developed in 2005 by Reeves and Zentil in Journal of Clinical Oncology. They took about close to 700 AML patients who had relapsed and gave them a score for various variables. And they found that the variables that were actually informative of prognosis was the duration of remission.